So pancreas cancer poses a number of challenges, and not least of all is that the incidence for this disease is on the rise. It's anticipated that this year there will be over 55,000 people diagnosed with this cancer. It ranks disproportionately high on the list of leading causes of cancer-related mortality relative to incidence, and there's been a steady about a 0.5 to 1% increase in the frequency of this disease over the last number of decades. If we take all comers diagnosed with this disease, the overall 5-year survivorship is about 8%, but it is of note that this has been slowly but steadily increasing. So a common question is, why is this cancer so challenging? And there are many factors that are put forward. We know that the microenvironment and the whole stromal context is very important with this disease, and it provides both a physical barrier to drug delivery. It's relatively avascular, and it's hypoxic, so can be sort of considered a hostile microenvironment. From one perspective, the genetics of pancreas adenocarcinoma are complex in that we see a number of frequent tumor suppressor genes and oncogenes that are mutated, none of which are effectively targetable in 2018. However, there are a number of lower frequency genetic events that are much less common, some of which are targetable in this disease. Arguably, we do not have validated biomarkers for routine treatment decision-making, although during the course of this review, we'll touch upon some that have become and are increasingly integrated into practice. And I think it's fair to say, while our current therapies may work well for a proportion of patients, there's inherent both primary and acquired treatment resistance to the best available agents that we have in practice. So looking at the molecular pathogenesis of pancreas ductal adenocarcinoma, this has now been well described, and this is one of the putative pathways for development of this disease, that normal ductal epithelial cells undergo progressive neoplastic change through Panin-1, Panin-2, ductal carcinoma in situ, and ultimately invasive cancer. Timelines for this may be protracted and over several decades, in fact, and as this process happens, there's an accumulation of genetic changes that are characteristic of each Panin time point. And it's also important to note that Panin-1 is common as we all get older, and probably the committal step in terms of development of invasive disease comes at the level of Panin-2.